bachelor by occupation, residing at Namakkal, presented with the chief complaints of non-healing ulcer in the left lateral border of tongue. Patient was apparently well 3 months back, following which he developed a non-healing ulcer in the left lateral border of tongue for 3 months, which was insidious in onset, gradually progressive, associated with non-radiating localized pain over the ulcer site. No history of fever, trauma, dental trauma, no ill-fitting dentures, no history of difficulty in opening mouth, chewing food or swallowing or excessive salivation, no history of ear pain, no history of loss of weight, loss of appetite, cough, hemoptysis, breathlessness. Patient does not give any previous comorbid illness or previous exposure to radiation. Patient is a mixed diet consumer.
But exposure to radiation predisposes to what type of cancer? It's not oral cancer. If you have a history of prior radiation, what are the tumors that you can expect in the future in a patient?
Thyroid malignancy,
yeah.
Breast malignancy.
Yeah. Then there is radiation-induced sarcomas also. Then any hematolymphoid disorders that can come from prior radiation. So lymphomas also. If there's a history of prior radiation, you'll have to know. So the question will be, if you make a statement in the history, they will ask you a question about that statement. So you said excessive salivation. What does excessive salivation have to do with oral tongue malignancy? When do you get excessive salivation?
It is in a locally advanced lesion, the patient not able to swallow.
So there is pooling of saliva sort of in the mouth. That is not excessive salivation. So you should, whenever you make a statement, there will be a question. Okay, so you said non-healing ulcer, left lateral border of tongue, 3 months duration. What is the other history that you have to ask? So what are the pre-malignant or potentially malignant lesions of the oral cavity?
Pre-malignant lesions are the
now it's changed to potentially malignant PMD as per the recent classification. So what are the potentially malignant disorders? So what history will you ask for that?
Leukoplakia, erythroplakia. I'll ask for previous history of any lesion or any injections or any surgeries. Has been done for.
So any altered mucosa. So you have to ask the patient whether he had any whitish or reddish patches on the tongue. Is lichen planus a PMD now? Is lichenoid planus the PMD now?
It is a malignant condition, sir. I mean, not condition, it's a disorder. That is.
Which one, lichen or lichenoid?
Lichen planus.
Are you sure? What's the difference between lichen and lichenoid?
Lichen planus.
That is a very recent question that they asked. Okay. So when you're discussing, suppose the history goes from, this is a typical history. Suppose they go into potentially malignant disorders. So you know which are the high risk leukoplakia?
Yes, sir.
Both based on site, based on sex, based on duration, and based on whether habits are there or not. Yes, so and then the morphology of the lesion, whether it is homogeneous, heterogeneous, speculated, all that. So that high risk thing you have to say in the exam. So this high risk can be classified into age, sex, duration of the illness, associated complaints, and habits. You have to spread it out. Then they'll ask you in the exam, what do you mean by habits? In smokers, is it more malignant, or in non-smokers? In male, is it more malignant, or female? Is fluoromorph more malignant than buccal? That you have to draw the questions out from the examiner. So you have to, any answer you give, you have to break it down into these headings. Okay. So you said no history of radiation. You said no other comorbid illness. Why is comorbidity important in an oral cavity squamous cell carcinoma?
The immunosuppressive state is also associated with increased risk.
Yeah, so what are the immunosuppressive states that you know are associated with increased risk?
Diabetes.
It is not proven exactly diabetes, but more importantly, anybody who's organ transplant who has immune suppression.
Okay, sir.
And the tumors in organ transplant immune suppression are worse than the tumors which occur in other patients. So we have a renal, and that also depends on the amount of immunosuppression. So if the patient has been weaned off suppose he's 8 years post-transplant, 10 years post-transplant, he'll be getting only corticosteroids. He won't be getting the other TAC and other drugs. So the risk is always there. And if they develop a tumor, they're at a higher risk for secondary tumor. So they ask you what is, and then the second thing is the patient's performance status dictates the results of the surgery and decides upon what type of treatment you want to give the patient. So there are many comorbidity scores, you know those, no? ACE scores, American College of Anesthesia scores, you know all the scores, no?
Yes, sir. ECOG score.
No, that is performance status. I am asking you morbidity scoring. Why is this morbidity scoring is important is that predicts the outcomes of surgery.
Okay, sir.
Suppose a patient has a very high morbidity index, like an ACE10 index is very high. Those patients are likely to have complications after free flap surgery.
Okay.
So if you mention the word comorbidity, read about 1 or 2 comorbidity scores that are available. Just name only. And what is the implication if they have a bad score? It is likely that they will not tolerate prolonged surgery, and after surgery there's a higher risk of complications. That is why we need to know the comorbidity. Okay. So history, this is fine. Think more than this, I don't think. You said about sharp tooth. You said about ill-fitting dentures. Both are correct. And you also mentioned that he has no radiating pain, which means that it is a more anterior tumor than a posterior tumor. And pain denotes infiltrative nature of the tumor. So we might not be dealing with a T1 carcinoma. It may be upstage during the evaluation and imaging. Okay. Clinical findings.
Yes. Sir, he is also known tobacco chewer and
okay,
smoker.
sorry, I forgot to answer. Yeah.
Tobacco chewer and smoker, sir. He smokes 10 BDs per day for 10 years, and now after developing this ulcer, he stopped his smoking and tobacco chewing.
Okay, so the important thing with this history is that it is very difficult to quantify BD smoking. Unlike cigarettes, it's very difficult to quantify BD smoking. And he is also using smokeless tobacco. He's also doing tobacco chewing. So it is very difficult. So if the examiner asks you, how do you quantify his habits? If it's a smoker, you know 20 pack years, 10 pack years, that thing is there. And what is the relative risk between the normal population and a population that smokes? What is the relative risk?
Sir, for smokeless, for dry tobacco, it is 4 to 11%. Sir, it is highest. And with any smokeless tobacco, it is 1.5 to 2.5. The lowest risk for wet tobacco and oral chewing is 0.9 to 1.5.
So you should know this relative risk of all that. But you should also explain to the examiner it is difficult to quantify BD and smokeless. So how many years has he been doing that?
10 years, 10. Sir.
Any associated alcohol intake?
Occasional alcohol, sir.
Okay. Don't use the word alcoholic because alcoholic has some criteria. Okay, he's an occasion. Then if your examiner is very, very particular, he might ask how many ounces are allowable per week, how many ounces is bad. The combination of both is worst for supraglottic tumors and hyperpharyngeal tumors. All those small things you should. Okay, then.
Okay, sir. No significant family or previous treatment history.
Can you tell me some familial or inherited squamous cell carcinoma syndromes?
Sir, Lee-Frommey P53 mutation, correct, Bloom syndrome, ataxia telangiectasia,
and xeroderma pigmentosa, and Fanconi anemia. So these are inherited squamous cell carcinoma syndromes. Okay, each of them are different. Like xeroderma is skin, Bloom's is this. They're all different sites, but these are inherited. And Lee-Frommey is the most important because it's a P53 mutational. Okay, the clinical examination.
On examination, patient is conscious, cooperative, moderately built and nourished with ECOG score of 1, BP 120/70, pulse 72, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema.
Clubbing, you will be very careful because
for chronic smoker.
Be very careful. Second thing you mentioned is how do you calculate the nutritional status of the patient?
BA. Body mass index, sir.
Okay, after that, how do you classify? Suppose I'm telling your patient has sarcopenia.
Yes, sir.
I ask you to measure whether the patient is sarcopenia or cachectic. What is the thing that you will measure on the patient? You have to do some circumference and all, weight, and
Bedam circumference.
Weight, then what else? So when they ask you about how to judge the nutrition, you should know how to clinically examine the nutrition. And there are some biochemical markers also. So this is how you assess. Okay. Again, this has a direct bearing to the response of treatment. Okay, people who have low BMIs, people who have features of sarcopenia or cachexia, they will not respond to any treatment. So that also. Okay. Then KPS or ECOG, which one did you use?
ECOG, sir.
No, ECOG performance?
1.
Okay, fine. Local examination?
Local examination.
And weight, all those things, pulse rate and BP, all those things you have to measure. Okay.
Local examination on inspection, the face was symmetry and he was able to open mouth adequately. He had a bad oral hygiene with nicotine stain and halitosis was present, but there was no obvious sharp tooth or missing or ill-fitting dentures. The tongue movements were normal with no deviation, and ulceroproliferative lesion was noted in the of size 1.5 into 1.5 centimeter. In the left lateral border of the tongue, extending 2 centimeter from the tip of the tongue and 1 centimeter anterior to the circumvallate papillae, not crossing the midline and well away from the floor of the mouth. Examination of the other oral subsite and neck is normal.
This is inspection.
Inspection, sir.
Okay.
On palpation, all the inspectory findings were confirmed. Tender, solitary ulcer of size.
In your inspection, you mentioned how much mouth opening, finger breadth, or inter-incisor distance, whatever, whichever you want to use, you have to mention that. And it's very rare for tongue deviation to occur without wasting of the tongue. Because in hypoglossal palsy, that is slightly different from other palsies. Because in hypoglossal palsy, the wasting precedes the deviation of the tongue. So it's very rare unless it is going into the neurovascular bundle and the patient has PNI going up to the hypoglossal canal. You generally don't see this deviation and all that. Protrusion of tongue you mentioned, that is correct. That is what is very important. So what is the normal protrusion of tongue?
Muscles you are asking.
No. Is there a criteria to say normal tongue protrusion? Beyond the incisors, how much should we be able to protrude the tongue? That's too much.
No.
Okay. It's 2 to 3 centimeters. There is a normal protrusion of tongue beyond the incisors. Okay. So you had an ulcer in the left lateral border of tongue, 1.5 into 1.5 centimeters. So what is your palpatory finding?
A single lesion of 1.5 into 1.5 centimeter palpated in the left lateral border of the tongue. 2 centimeter from the tip and 1 centimeter anterior to the circumvallate papillae, which was irregular in surface with everted margin and not crossing the midline.
See, you said it's a proliferative.
Yes, sir.
And what you're talking about, everted was ulceroproliferative.
Yes, sir. Ulceroproliferative.
Okay.
Not crossing the midline and 2 centimeter away from the floor of mouth. Does not bleed on touch. And palpation of the base of tongue was supple. Other subside were normal tongue.
What about induration around the ulcer?
Sir, there is no extension of induration beyond the ulcer.
Okay, so the ulcer is confined to the margins. So there's no induration.
No, sir.
Okay, so what else should you do to? How do you palpate induration?
Sir, induration is a palpatory finding.
Yeah, how do you palpate?
Sir, around the lesion.
Okay, suppose you want to say this is
due to field cancerization.
Who gave the task?
Slaughter et al. in 19.
Then after it was modified by whom? There was a Hong modification. And there's a Warren and Gates modification also. So you have to read all these.
Warren and Gates.
Hong.
HON.
Hong's modification and then Warren. So what you said is exactly correct. Whenever you examine an oral cavity primary, you have to look for other sites. Okay. So the other sites can be in the field cancellation, there's a size criteria. Within certain size, it is considered part of the main lesion, satellite lesion. If it's beyond 2 centimeters in size, it is considered to be a second primary. Now, second primary can occur anywhere in the aerodigestive tract. It can be in the lung, can be in the esophagus, it can be in the thing. But for a T1 lesion, it is quite rare. As the lesion becomes more advanced, you have to actively look for the second primary tumor. Now, Brackwis molecularly classified second primary tumor, the free paper. If you don't have any of these papers, I'll mail it to Saravana, you can take it from. So, the previous was only clinical based on distance and time duration. They classified second primary, metachronous and all those things. Now, Brackwis has given a molecular classification for what a tumor is, whether it is second field tumor or second SPT, SFT is given classification. So that I will give it. Okay, so finally, what is your, and neck you examined?
Yes, sir.
Neck was negative.
No.
Neck. So what is the size that you criteria you use clinically to judge whether a node is significant or not?
1 centimeter, sir.
No, is it the same for all levels of neck? No. No, you're palpating the neck and you're feeling this lymph node. What is the clinical criteria for saying it's a significant node or not?
Firm to hard in consistency.
Okay.
Firm to hard in consistency.
Then?
And if it is mobile or
correct. So there's extranodal extension. It can be mobile or fixed. Then
Round node.
how can you palpate? It's very difficult to say by clinical palpation which is over. So size criteria is more important. So for 1A, 1B, what is the size criteria? For Buglodigastrate, what is the size criteria? So there's a clinical and radiological size criteria for both. So you have to, so that is the only question that they can ask. And then different sites, where do they drain?
Yes, sir.
Okay.
Tip drains to submental, lateral to submandibular, and posterior is jugulodigastric.
Yeah, lateral can be submandibular and jugulodigastric. Then you have to talk about lip. So which are the sites that have bilateral?
Bilateral tip of
tell me all the sites.
Sir,
I'm talking all sides, starting from skull base to leg.
I'll tell whichever I know, sir. Lip, lower lip.
So start with nasopharynx. Nasopharynx.
Okay, sir.
Then
lip.
base of tongue.
Base of tongue and tip.
Base of tongue, tip. Then lip. Then supraglottis.
Okay.
And then thyroid. These are the structures that have bilateral nodal distribution. So they can affect both sides of the neck by passing. Okay, so you examine this patient for the neck is negative. So clinically, how do you give your clinical diagnosis?
Sir, next is always in clinical radiology.
No, clinically, what is your diagnosis?
My diagnosis is carcinoma of tongue.
You can't say exactly carcinoma. It can be adenosquamous. It can be anything. So what?
Malignant.
Correct. Malignant lesion of the left
lateral part of the tongue.
Clinical stage?
Staging T1 N0.
T1 N0, stage 1.
Yes, sir.
Possibly squamous cell carcinoma. Why squamous cell carcinoma? Because there is a commonest histological line. So how will you proceed with this patient?
Sir, I would like to do imaging and followed by biopsy of the lesion.
Okay, what imaging would you like to
do? MRI of the oral cavity and neck.
Okay, in the MRI, which sequence will you use to assess? So what are the advantages of doing an MRI in this patient?
Sir, MRI, soft tissue delineation and depth of invasion we can...
See, depth of invasion is overestimated in the MRI. Only high frequency ultrasound has been found to have good correlation between depth of invasion and the actual lesion. MRI overstates the depth. There is no correlation like that ever proved. There is a correlation saying that it might be bigger or smaller, but not exact size. So you can't make up. So first you say it's got good soft tissue delineation. I agree to that point. Second, what can it do? What sequence will you use?
Sir, T1, T2 and
so it is T1 contrast and stir. T1 contrast and stir. These are the two sequences that you normally see in MRI. So first you want to see the site, then you want to see the extent, and then what else do you want to see?
Perineural invasion.
But before perineural invasion, what do you want to see?
Sorry, extent, local extent, and
That
posterior.
also is fine. All that we discussed. Then you have
Crossing the midline.
Okay, that also I agree. Then what else?
Flora of mouth.
In the flora of mouth, what do you want to see?
And then
Sublingual
space.
gland.
Sublingual space. And then what else you want to see? Perineal invasion. What are the signs of perineal invasion in MRI?
Widening.
But hypoglossal canal is in the back.
There will be atrophy of the tongue.
So if there's atrophy of the tongue, what will be the MRI findings? Early atrophy, late atrophy, what will be the MRI finding?
Early atrophy will be associated with edema.
Early atrophy is associated with edema. So in a T2 sequence, it is right. Late atrophy is caused by will result in loss of bulk and asymmetry to the opposite side. More important, there will be contrast enhancement along the neurovascular bundle. And then, like you said, there will be a widening of the foramina. Then there will be denervation signs, that is atrophy and denervation. Then there is a fat pad between the two ends of the foramina. There is a fat pad below the foramina and fat pad above the foramina that will be obliterated because of the perineal invasion. So you have done the MRI for both the primary and the neck node. Okay, so for neck node, what is the best sequence? Everything is fat suppressed. Whatever contrast sequence you use is fat suppressed. Okay, evaluating neck node in an oral tongue carcinoma, which has got the highest sensitivity, highest specificity.
Ultrasound.
Both high sensitivity and
specificity is high.
Okay, then which has higher sensitivity? So who gave that paper? Which meta-analysis was that? I'll send all this to you. Which meta-analysis was that? There are two meta-analysis published. Which was that? There is one which is quite old and there's one which is quite recent. So ultrasound has the highest specificity, so you want to see with your. But MRI also you're going to get the same information in the MRI. And you know what are the bad features on MRI? The size, shape, fatty, high